The last presentation is really a planning presentation because this project is about to be launched. And you've already heard from Chloé Buso. And this is a dual presentation by the two researchers that are conducting this project with the help of Dr. Dalton, so that it ties in to the University of Waterloo as well. And I think, Chloé, are you going first or both come up? And I've already introduced Chloé, and now I'll introduce Jeremy. Jeremy is an engineer who is working with us on concussion, and he graduated from McMaster with his bachelor's of engineering, and then at U of T, he took his master's of engineering, and now he's doing this important research work on concussion in a number of studies with the Canadian Concussion Center. And please come and tell us about the project that you are engaged in, and the title of which will take about 20 minutes to get across. So please, who's first? Please come.
Okay. Where's the clicker?
Yep.
Oh, the click. Oh, here it is. So hi, everyone. Today, Jeremy and I are going to be presenting our new study, which was recently approved by the REB, where we'll be examining critical flicker fusion frequency, the pupil light response, and intrinsically photosensitive retinal ganglion cells in concussion patients with computer screen intolerance. So in my last talk, I gave a lot of the background information for the types of tests that we're going to be doing in this study. For critical flicker fusion frequency, we're going to be looking to see if the magnocellular pathway is involved in computer screen intolerance, which, as I mentioned earlier, that is where we detect the motion of light. And then we're going to look at the pupil light response and the intrinsically photosensitive retinal ganglion cells. So just to add on from what I said earlier, the pupil light response is when the pupil constricts in response to light and when it dilates in the darkness. And to do this, we're going to be stimulating the pupils with two different colors of light. We're going to be doing the red light and a blue light. And so to drive the pupil light response, that's with rods, cones, and the intrinsically photosensitive retinal ganglion cells. And rods contain an opsin called rhodopsin, and that is activated by red light. And so when the red light will hit the pupil, it's going to stimulate the phototransduction pathway, which is going to convert light into an electrical impulse and send it to the brain. And then the brain is going to signal the pupil to constrict in response to light. And so that's our primary pupil light response. And then we're going to target the intrinsically photosensitive retinal ganglion cells by using a blue light. The iPRGCs contain melanopsin, and that's activated by blue light. And as I mentioned earlier, the reason we're interested in the iPRGCs is because it has been postulated that these cells have monosynaptic inputs that project directly to the thalamus. And so we're curious to see if this is another mechanism involved in the pathophysiology of computer screen intolerance.
All right, Chloe, thank you for the background. Dr. Tyler, thank you for the introduction. So I'm just going to run through some of the study design things that we're looking at here. So we'll start with the objectives and the hypotheses. So, oh yeah, sorry about that. For the virtual people, for sure. So primary objective, as Chloe's talking about, we are curious to determine the pathophysiology of CSI, computer screen intolerance, in concussion patients with persistent concussion symptoms. And we're also, while we're doing this, we're going to look at an exploratory objective, and that is to determine if pupil size will actually have an impact on the critical flicker fusion frequency thresholds that we'll be measuring. So we have two hypotheses for this. The first of which is that the brain cannot properly fuse incoming flickers of light after a concussion, so that's why we're measuring the critical flicker fusion frequency. As well as a second hypothesis that the forces transmitted to the brain during a concussion will impair the intrinsically photosensitive retinal ganglion cell-driven pupil light response pathway. So we'll go through the inclusion and exclusion criteria here. So this is for the concussion with persistent concussion symptoms patients group. There's a different set of criteria for the healthy controls, but for the interest of time, we'll just go through this. So the C plus PCS patients must have sustained their concussion between 1 month and 5 years of their study visit and have at least 3 persistent concussion symptoms, one of which has to be computer screen intolerance, of course. They need to be between the ages of 18 and 65 and be able to read, write, and speak in English. We'll be excluding for a variety of pre-existing conditions, including neurological conditions, psychiatric conditions, and visual disorders, as well as for brain injury more severe than concussion. So I'll walk through the protocol here. As Dr. Tatter mentioned, this is a study in progress, so we're just going to talk about some of the methods. So we'll start with how we're administering the questionnaires and which questionnaires we will be administering, as well as how we set up the pupil measurement device. We'll look at how we'll evaluate the critical flicker fusion frequency thresholds, and then the pupil light response methods as well. So we'll just go through that now.
So when the concussion patients come in for their visit, we're going to be administering 4 questionnaires. 3 of these are standardized concussion questionnaires. So we have the sports concussion assessment tool, the brain injury vision symptom survey, the headache impact test 6, and a computer screen intolerance questionnaire that we designed. And that's just questions related to how sensitive they are to screens and to get a better sense of the average screen time per day that this population spends. And then in our second cohort, which is going to be the healthy controls, they're just going to be filling out this computer screen intolerance questionnaire too, so we can get a sense of how screens affect healthy people. Then when patients come in for their study, we're going to first calibrate this device. And so to do that, we're going to place this sheet of paper in front of our eye tracker camera, which is going to calibrate the pupil diameter. Then we're going to put the Viewpoint eye tracker glasses on top of, or the patients are going to wear them. And then I'm going to make sure that the camera, it's an infrared camera as well as an infrared light that is placed in line with the pupils. So that way, when we're calibrating it, you should see in this image, the yellow circle should be steady around the pupil. And that's how you know that the device is ready to undergo calibration. And to calibrate, we're going to be using a 9-point grid, and a color is going to flash in one of these circle locations, and the participant is going to have to look at where that light is in order to undergo calibration. So I'm going to walk you through quickly how we're going to be administering this test. First, we're going to be measuring critical flicker fusion frequency, and to do that, we're going to be using the handy flicker device. This test is going to take place in a dark room, and we're going to be using a staircase method. And what that means is we're going to have 2 trials, one with the red light and one with the green light. And so with the red light, we're going to increase the frequency until the patient no longer sees any flicker. And then I'm going to decrease the frequency until the patient sees it start flickering again. And I'm going to repeat this up and down, which is going to count as 1 cycle for 3 times per each color of light. And so we're going to do the same thing using the green light, where it's going to increase and decrease based on the patient reporting whether they see it start or stop flickering.
Okay, so just to expand on what Chloe was saying, I want to show you what the data might look like. So as she mentioned, we'll increase the frequency until the patient can no longer perceive individual flickers, and we'll call that's the ascending critical flicker fusion frequency, and then it will be decreased until they can once again perceive these individual flickers, and that's the descending critical flicker fusion frequency. And then to calculate the actual value, we're going to take the average of these values, and this will be done for each trial. I mentioned earlier an exploratory objective, which is to determine if pupil size will impact these thresholds. So we'll be monitoring that throughout with the eye tracker that Chloe was talking about, as well as we have a scene camera on the front of the eye tracker device that will record what the patient is seeing, so that we can co-register the pupil data and the critical flicker fusion frequency data.
So for the second component of this study, we will be using the color burst device, which is pictured here on the screen, which Dr. Dalton so graciously lent our team to be using. And to use this, patients are going to undergo dark adaptation. So this will also serve as a break between the critical flicker fusion frequency testing. But I'm going to walk you through the protocol of this test. So we're going to be measuring this one eye at a time. So in the dark, we're going to collect a baseline measurement for 10 seconds. Then the device is going to turn on for 5 seconds using the red light to stimulate the primary rod and cone pupil light response. And then it's going to go dark again, and this is going to be allowing us to assess the recovery period for what happened to the eye after it's exposed to the light. And we're going to repeat this process for a total of 3 trials per each eye. Then we're going to follow the exact same procedure using the blue light because, as I mentioned earlier, the blue light activates the intrinsically photosensitive retinal ganglion cells, and this is going to be the exact same protocol.
So again, I'm just going to talk briefly about the data that we're going to get or we're expecting to get from the pupil light response here. So when the stimulus is presented, we would expect the pupil to constrict, and then we can calculate some metrics from the initial constriction and how it recovers to baseline. So these 2 key metrics that we're going to be looking at are the constriction amplitude and the PIPR, the post-illumination pupil response after 6 seconds. So the constriction amplitude, we can get some important information about the initial rapid constriction. And then when we're looking at the PIPR, this is an important metric when we're looking at the involvement of the intrinsically photosensitive retinal ganglion cells. So this is just a preview into the data analysis and how we can maybe see some differences in the metrics between the concussion patients and the healthy controls. So thank you for listening. Of course, happy to answer any questions. Yeah, thanks everyone.
Most important aspect of the protocol, and that is that I have volunteered to be the first subject. And I did that because I wanted to be sure that we're not going to get into trouble with the Research Ethics Board, because we said these are completely painless, won't kill anybody, etc. So any suggestions for this protocol? That now is the time to say something that might alter our system? Good. No objections. So thank you very much. And we're open now to discuss anything we have a few minutes left. I'm not sure how many people who are online are still there. I don't see any questions from the online audience. Dr. Rizzo?
Yeah, Charles, a Nobel Prize may be in the making. You know that the person who postulated and proved that H. pylori is a cause of peptic ulcer disease, who's an Australian gastroenterologist, infected himself, treated himself successfully, and went on to wield, I think it was a Nobel, but it was a prestigious award nonetheless. And I think he's still alive.
So you're predicting something great for me.
Well,
Okay.
no. Even greater, because I have a new metric, if you'll allow the metaphor. You know, we talk about dog years. You know, there are patter years. In what you've accomplished, humans would take 6 times more in the multiple hats you've worn and continue to wear. And that was, you know, unpracticed, unadulterated, and certainly not required or requested. But I do have a question.
Go ahead.
For Dr. Dalton. So again, to use the metaphor allowed by one of my hand surgeon colleagues, he says that he feels more important than his skill in the operating room is to decide who to operate on. And with that in mind, the preamble is that while I have had great experiences with the successes of athlete patients I've been involved in their care, again, it's a small sample and it is skewed, they have had good results. And when I scan my colleagues, there are, in the MD world, there's a variability of acceptance, of feelings of application. Part of it is, one of the criticisms I've heard is the testing and the treatment is random, continues for long periods of time, even when patients get worse. So to get to the question, while I know that you have some very skilled physicians who refer to you, one is a pediatrician who's a sports medicine physician. I wonder, in the patients that you have, after you've screened them with your evaluations, is there a component? How big is that component that you say, you know, I was referred because the person had quotes unquote, really just general vision problems. These people aren't candidates. And when in the trajectory do you say, I've either not been successful, I plateaued, or the patient's getting worse? And believe it or not, even in the MD world, we have people who get worse. So, yeah, so that's my question.
That's a great question. And it's challenging. I think fundamentally the basis of where we progress with care is that it has to be patient-centered. That really has to be our foundation. And so when people present for, I will say, I see a very biased population because pretty much everyone who gets to our clinic has vision symptoms already. And sometimes they can be 2, 3, 4 years out. But I don't see a lot of patients that don't have vision symptoms to present with. So when I do assessments, the majority of the people I see have vision issues because they've had vision symptoms for a long time. That being said, when it comes to vision therapy and conversations about therapy, I always start with glasses. And when it comes to vision therapy, it's always in partnership with the patient. So what other therapies are you doing? What kind of time do you have? And what would work best for you? Is it an at-home model? Is it an office model? Is it a not right now model where you have other issues that you need to prioritize first, and then we can recircle the vision at a later date if you want to. So it's really trying to change. So my approach to vision therapy at the school and what we found in our brain injury clinic was founded on my approach from being a patient that spent most of my teenage years in and out of rehab for a variety of various surgeries, including a major spinal fusion at 13. So I grew up in a rehab setting. And so the approach we're trying to develop at the school to provide vision therapy is based on that foundation in rehab, not in some other space. And so we start small. We offer vision therapy, offer options, at home, in office. What do you want? There's no one size fits all. And then if you want to pursue therapy, I don't see patients for years or even multiple months without reassessment. I will do no more than 5 in-office sessions without reassessing a patient, because I think we need those frequent reassessment numbers to decide if it makes sense to do another block of treatment or not. If someone's doing at-home therapy for 4 to 6 weeks, when they come back in, it's a reassessment, and then we tweak their program based on their numbers and adjust exercises based on what progress they've made or haven't made and how we adjust things. And that's a model I'm trying to teach my students and optometrists of the future. So I get to work with 90 students a year and try and change their attitudes towards therapy. But it's certainly a model that we're trying to move forward and provide support for and research data for. And then conversations about ending again are patient-based. But if numbers aren't changing, it doesn't make sense for me to have you in my therapy clinic spending your time and money and energy on therapy. You could spend that on enjoying the progress you've made in rehab.
Thank you.
Right.
Thanks.
Well, I guess this is going to be a question and comment to us all. It is the question of whether we in rehab with patients with persistent post-concussive symptoms, whether we want to go the road of retraining the system, which vision therapy and vision system in general is sort of a good candidate for, or whether we will do compensation, that is teaching the patient how to live with whatever deficits are now part of their lives and are influencing us, but not necessarily the way that we cannot have a good life. Actually inspired by a recent talk where the talk was on constraint-induced cognitive therapy. I don't know if you are familiar with the concept. Constraint-induced therapy is probably one of the most therapies that is best evidence-based. It is based on foundation. It's founded on knowledge of plasticity and learned non-use, and then behavioral training, behavioral retraining. And the main concept is massing of practice, that is doing the training at a high intensity, and then also transferring the skills into an ecologically valid context. Now, and this has, I mean, it has been used for motor functions. It has been used for aphasia. It is now being used for cognitive functioning, and it follows this line of retraining instead of teaching how to live and teaching how to compensate. So I thought it would be interesting to hear your perspectives or others' perspective on how much should we retrain in vision and vision symptoms, and how much should we try to teach how to go about it.
Great question.
It's a fantastic question. And it's a challenging one. I think as a clinician and a provider of vision therapy, when I'm looking at retraining, for me, retraining is, are there measured deficits? Can we try and get you back to what might be clinical functional norms in those deficits, or make progress from where you are? So if your accommodation is reduced, if your near point of convergence is reduced, can we retrain those to function better? But we're also layering in, you know, if you have an uncorrected prescription or an improperly corrected prescription, that's really a structural issue that needs to be addressed first. Then we can work on some of the functional training. But I think when it comes to, at least in my head, when it comes to vision therapy and how it supports concussion, we can't do that retraining without also encouraging habits that allow them to function in daily life. So we also have conversations about pacing and planning with screen use, appropriate breaks, accommodations, ways they can adapt their environment alongside that training to try and improve their symptoms. And at least when I think of my background in sports injury, and I think of the approach to care that we try and take at the school, and where I think some of this falls is, I often think, you know, when I explain to my patients, a concussion, right? If you think of an athlete with a sprained ankle, right? Like a soccer player, I was a soccer player. They may end up with multiple sprained ankles, but still be able to play soccer, but still be wearing a brace. And maybe that's their normal, but they're not pre-injury normal, but they're wearing the brace. So they've got some sort of adapted function, some sort of rehabilitation, retraining to function on that ankle, and they can still play, right? And that's kind of can be, you know, your patients with multiple head injuries. Maybe we can retrain some of this, but maybe you still need that prescription, or maybe you need some filters, or maybe you need a planning and pacing plan for screen use to be able to function, right? And then alternatively, we have people who have had, you know, someone with a fractured femur, you know, they'll be rehabilitated and able to walk again, but they may always walk with a limp, and that limp may be part of how they adapt their life and plan and pace around that. And I think we can also have a single head injury that can be one that can really throw you off. And we can't get back to 100% pre-injury normal, but we can move to a point where you're, you know, looking at your numbers, where you reach an endpoint, and then we also think about how we adapt around that. And that's kind of how I think of therapy and vision therapy as a supplement is, you know, we need to retrain, try and retrain, but also be open to the fact that retraining is not always fully possible. And so we need to also remember about accommodating and functional adaptations to life too.
Before we take another question from the audience here, there are two questions now from our virtual audience. Is there any imaging being done on brain optic nerves to see if there is a correlation of changes in these structures that might relate to vision issues? Great question.
There are a few studies. I had some of the references in my slides. I didn't speak to them, looking at optic nerve volume, retinal vasculature, and retinal nerve fiber layer thickness. And I think perhaps, Karen, in some of those studies, I'm not sure if they correlate to function yet. I'm involved in a study, which is the EPIC study, the eye problems in concussion and concussed children study, running at 10 clinical sites, 9 in the US and 1 in Canada. And we're seeing kids within a month of injury, and then at 3 months and 6 months, or at 1 month and 3 months post-injury. And we are doing clinical measures, cycloplegic refraction, as well as imaging and visual fields in that study. So we're trying, I think their study's moving towards that now, and hopefully they will continue.
Actually, the measurement of the retinal layer thickness has become quite common. And we can do it now quite easily, right? So might that be a good index of recovery, I guess, as the question shows thickening up from a layer that
I-
has become thin.
I don't know if the retinal nerve fiber layer will re-thicken following recovery and damage to the neuronal cells, but I think it's an injury. It can be a marker of damage and persisting damage. Whether or not the nerve fiber layer will respond to treatment and get thicker, I don't know. We look at other mechanisms of retinal nerve fiber layer disease, like things like glaucoma, that damage doesn't repair. You just try and slow it from getting worse or prevent it from getting more worse. So possibly retinal imaging could be a responsive to treatment, but I'm not sure yet because it's neuronal cells and neuronal pathways if they'll respond the same way.
Here's another great question online. How about considering a long-term study to determine the ideal order of therapies? Where should vision therapy be positioned before or after other therapies?
I love that question, and I would love to work with as many people as possible to try and answer it because I think at the end of the day, one of the challenges of concussion, it's so heterogeneous and everyone presents so differently that, if your symptoms are cranial sacral driven or they're not, like, depending on what your primary symptoms are, those are, your biggest things you need to address first, right? And if vision is one of those pieces, maybe that's earlier, but if vision is a smaller symptom and you have larger issues, I think those are where you start first, right? And I don't know the answer to that, but I'd love to try and figure it out.
Dr. Ritter is going to tell us the answer. Go ahead.
Yes, you have an unlimited faith in me. But no, I would also like to collaborate on that study. And I definitely agree that the way to go forward is person-centered and personalized approach. We have back in 2019, we have published like the first bigger trial on specialized a specialized multidisciplinary or interdisciplinary rehab in this area, and that has sparked many different trials that are ongoing now. No matter how, and we actually have another one trial going on in Denmark where we have actually tried to make a what's called manualize the therapy. What it boils down to is that we always need to make it very personal to the needs. I would like to, into the future, I would really like to also assess the component of the neck when we talk about when we talk about concussion and vision problems and headache and this complex of where does it actually come from and how is it related to each other. I also know from a clinical perspective, there's, at least in my part of the world, there maybe sometimes be this competition between physical therapists and, for that matter, optometrists to say, treat the neck first, or no, we need to treat the eye first. But I do think that the answer is going to be variable depending on the person that we have in front of us. So we will not be able to make a standard algorithm for what needs to go first, second, third.
Carmela, do you want to comment on the sequencing of therapies in terms of all your studies of return to work?
Yeah, no, I think those are great questions. And I really do think that we need a personalized approach and we need them to happen in parallel. I often see people who have terrible headaches, they don't sleep well, and they've been put through all this therapy. And of course, the patients are not well. Of course, I have a bias sample because a lot of times a patient have persisting symptoms and they have tried a bunch of things. But you think of it from other disciplines, it doesn't make sense because if somebody's got a broken leg and the leg hasn't had union, you don't put them through physical therapy. You let the leg heal. So it's the same thing. The person's not sleeping well. They're, have terrible headaches, and then they're going to vision therapy and they show up in our clinics and they're like, I'm vomiting after I leave. And it's like, okay, well, there's obviously some disconnect here. And oftentimes I think that unfortunately the people who are supposed to be the quarterbacks, they are ill prepared for concussion. And so we're trying to change that in the family doctors, the primary care, so that they're the quarterback and they're saying, okay, we need this kind of comprehensive assessment and therapies so that the patients unfortunately is not going to be sequential, right? It's going to have to be in parallel. But some things make more sense than others.
Yeah, I think this sequencing question is really a great issue that we just have not sorted out or.
And I just want to comment
ahead.
on this because one of the issues that we also need to be very attentive to this that is the development of mental health issues. Because if you are struggling so much, well, be it because of the symptoms and symptom load or because of the primary injury, it doesn't really matter whether it is a primary or secondary cause to your mental health struggling. But that is a layer that needs to be actually taken care of. And sometimes even prior to a very specific therapy, because that can definitely prevent people from. So there was just a little.
Just sorry, this
Dr.
similar thing
Ansari?
to emphasize to Dr. Tartaglia's point. And I'm biased because I'm very focused on treatment of headaches and concussion, but I think it's a major part of it that can actually increase patients' persistence with the therapies, including the vision therapy, physiotherapy, vestibular therapy. And yeah, it's a big part of it. Sometimes with treatment of the headaches in some patients, again, personalized approach is very important. But sometimes with treatment of headaches in a lot of these patients, a lot of these symptoms disappear or at least decrease significantly.
Yeah, all very good points. Dr. Reber?
I have two comments. One is about the order of the therapy, and we work a lot in Europe with people with stroke specialists, and maybe we should think concussion a little bit as a stroke. You have an acute phase, and then you have a post-stroke or post-concussion phase where symptoms can last for a long time. So typically with stroke, now we are discussing with those guys that we will combine at the same time vision rehabilitation together with physical rehabilitation, which typically in stroke, as soon as the patient recovered from the stroke, they start physical rehab, motor rehab. So the idea is to do in parallel both vision and physical rehabilitation. And I would like to comment on your question about re-education or retraining versus compensation. Maybe we shouldn't see those two as separate. We finished a study recently with a patient who had AMD. Basically what we were doing is, so if you have AMD, you naturally develop compensation strategies to see better or to get better in your daily activities and daily life. And so the idea with the low vision specialists here at Toronto Western was to identify how those patients would compensate for their loss of central vision and then offer a rehabilitation or visual rehabilitation intervention for 4 weeks and to see how this goes. So that's one option. And then we just also finished and published a pilot study with children with brain tumor who had hemianopsia. And there, our focus was more about retraining. So of course, you can compare those two populations. One was average age 12 or 13, the other was 86. So retraining, relying on brain plasticity and so on, it is much more efficient in 12 years old or 13 years old than it is in 80 plus. Not saying that it doesn't exist. It exists, but it takes way more time. So maybe, we should think about combining those two concepts and strategies to make it even more efficient. And I will push it even more. When we walk around in our daily activities, we use vision, but we also use audition, right? Detecting elements around in your environment involves both multisensory processing, and it's been shown multiple times that if you combine both, you are way more efficient in detecting what's going on around. So one of our rehab approach uses both audition and vision to rehabilitate vision, actually. And it's way more efficient than when you were asking earlier today, how long should people go into rehab? There must be a stop at one point. You're not going on rehab for decades, right? Typically what we've seen is like 6 weeks of audiovisual stimulation, and you already recover a lot in terms of vision. So we also maybe need to think about, again, having a comprehensive approach. Our body is one, all our senses work together. So if we stimulate all of them at the same time, maybe we can favor a recovery much faster.
Thank you. I think, do you want the final word?
It's up to you. I was just, I had a comment on the sequencing piece and the headaches, because as a vision person, oftentimes we see people presenting with headaches for an eye exam, and interestingly, it's another common symptom we'll see as well. And oftentimes we'll see things like uncorrected refractive error contributing to headaches as a structural foundation piece. So while I think vision therapy can support headache therapy, I don't think it comes before addressing structural issues like refractive error and other disabilities first, and start with refractive error and do it well, and give them time to adapt to that and see what else comes out, right? Because that uncorrected refractive error may also be contributing to headaches and vice versa. And so it's really it needs to be a collaborative approach, but I like the idea of working together to address structural stuff, and then prioritize patients' needs, right? And see what goes next.
I agree completely. And those two patients that I just mentioned are so bothered by the fact that they've lost their distance vision. That is a first thing to correct. Well, I think we've all had a great opportunity to learn today. That's the purpose of this symposium. Thank you to Mojgan Kodadati and Arizu Kodadati for organizing. And Christian Peterson and team is in the back. Thank you, Christian. We appreciate your efforts to get this out there. And thank you to this very active audience for all the great questions and for your attention and support. Thank you.